I have a question for Amy. Just we're onboarding some commercial gene therapies down at Stanford and wanted to just get your experience with the insurance authorization for private insurance and if you've had any public pay through Medi-Cal as well.
So definitely private insurance has been, I don't want to say easy, but easier. We have finally have our first public pay. We have a CCS patient that we are going to collect in June. But the public insurance, private insurance has been easier, but it still takes a long time. And it really is just insurance dependent on what the company is.
Do you have any recommendations, I guess, for when we, especially with like just moving forward with insurance authorizations or any things that you found successful or that helped with that process?
So what we did find out a little bit after we started all of this is that a lot of the insurances do have specifics of what they want. And so it's really important that you have your authorization specialist see what evaluations need to be done and make sure you submit all of that when you are getting your authorization.
Thank you.
I have a question for you also, Amy. I believe it was you that were talking about the Plexifor and the inpatient admission. And you said you were able to collect all in one day. Sorry, I'm a little short. So I'm just wondering, with bed capacity issues, if you guys have considered potentially not having them admitted in order to do that, since you have been able to collect all in one day, if that's a discussion you've had at all, or if you're just like, yay, we did it one day and we saved our apheresis time. So
yeah, so we've been able to meet the manufacturing goal in one day. So it's always going to be at least a 2-day collection. So we do the backup, but because we put the temporary lines, which are usually IJs in, it's just not safe for our patients to go home. So we keep them in patient until their IJ is out.
Okay, so it's more related to line placement than it is the Plexifor scheduling.
Exactly. Yes.
All right, that's helpful. Thank you.
Additionally, the kinetics for mobilization for sickle cell versus thalassemia patients are totally different. So
that is true. I was talking specifically about thalassemia. For sickle cell, they don't use GCSF at all, so they would be inpatient. They would get their line placed, get a red blood cell exchange, and then we would do the collection the next day. All inpatient.
And so just a clarification question. They're making you do a MUD search before authorizing?
Majority of the insurances are.
Wow.
I know.
Seems like a waste of resources. I actually had a question. A lot of these are technologies that are used for a ton of different indications. And one of the questions that we're coming up against in the field is whether these should all be warehoused in the same sort of clinical domain, right? So, Beverly, you were talking about how CAR T cells are now being used for things like SLE and, autoimmune disorders. Most of us grew up doing CAR T for heme malignancy, and now there are often immunotherapy, clinical teams who are mostly oncologists. How do you envision as we expand these into, obviously there are things that are in common, right? Whether it's Zolgensma or, Vyjuvek, but also there are a lot of things that are different. Do you envision continuing to warehouse these in the same clinical teams at your institutions?
I think this is a difficult question. I know that we've had a lupus CAR T cell clinical trial come through, and so the oncologist is doing the CAR T part, but the rheumatologist is doing all the follow-up. And so there's a lot of discussion about, is that the right way? Is that how to do it? I don't think we know yet.
Well, for us, for where I'm at, we are on the oncology, hematology, bone marrow transplant unit. So for me to bring in, and we're pediatric. So for me, I see it keeping it separate. I think it would be really hard to bring in CAR Ts for other indications.
My question is kind of along those same lines. So I'm at Stanford as well. And so we have like 6 CAR T studies coming for autoimmune diseases, like one after the other, after the other, after the other. So there's been lots of discussion about where those patients are going to be housed, right? Are they going to be housed in the BMT unit? Are they going to be housed on the neuro unit? Are they going to be housed on somewhere else? So there's a lot of question about fact accreditation, cellular competency, and the discussion is just kind of like blowing up all over. So I just wanted to hear your perspective on that. Thank you.
Well, uh, when you bring up the fact accreditation, I can kind of backpedal a little bit with what I said. I do think that it probably would, if we did treat those disorders, it probably would live with us in bone marrow transplant. Because I know with CAR T, we don't actually do CAR T commercial at Oakland campus. We do it at our San Francisco campus. But when we did have trials, it did live with bone marrow transplant. So I think that if we did expand to different disease processes, it probably would end up in transplant.
So I think at UCI, we're, working with logistics. This is a new for us. For outpatient, the immune cell therapy, so we use the PPCU, and we're also for CAR T cells, we for example, depending on the PI, if we are going to treat lupus with CAR T cells, the PI will be rheumatologist. So we're still working with the hematology to figure out what is the best way to manage this CAR T cell. For example, CAR T cell treatment for neurological disorders. We don't think it is appropriate for hematologists to manage this. So we also ask our neurologists to finish the 10 units CME in order for them to manage this.
All right, just to sort of round out the discussion, Pablo, you're taking care of like 7 different diseases with the same cells. Is that all in the same place?
I mean, I think it's similar where we have certain people who are involved because of their expertise, but it's still housed in or the PI'd by the different departments. So for retinitis pigmentosa, we're working with an ophthalmology group, but we're still involved for the cell aspect. For ALS, we work very closely with the neurology, but because of immunosuppression, we also work with the transplant team because they have the most experience with immunosuppression and particularly for ALS, there are so many comorbidities and con meds that it really is important to make sure to manage the whole patient. For stroke, again, it's neurology. So we really have small teams that combine, but we're working with some potential CAR Ts for other indications, like I think SLE is the one we're looking into right now. And it's the same thing. We have the 2 or 3 teams involved in the trial, but the PI is usually a PI from the indication that's being studied.